All right, welcome to part 3, diagnosis and assessment. So, after defining abnormality and looking at the major ways abnormal behavior is explained, the next big question is this. How do clinicians actually figure out what is going on? Because let's be honest, noticing that someone is distressed is one thing. Naming the problem carefully and responsibly is another thing. Hindi pwedeng nakita mo na lang na tahimik, irritable, at pagod tapos diagnosis agad. Baka thesis week lang. So this part is about how clinicians identify, evaluate, and differentiate psychological disorders. In short, this is where abnormal psychology becomes more structured and more practical. Dito na pumapasok ang assessment, diagnosis, and then yung clinical judgment, no, very important, and the reality that one symptom can belong to many different conditions. Okay? So, why does diagnosis matter? Diagnosis matters because it gives clinicians una shared language. If one psychologist says a client has panic disorder and another professional reads that case, there is already a common framework for understanding the pattern of symptoms, likely risks, and possible treatment directions. Of course, it also matters because diagnosis helps organize treatment planning, communication, research, and documentation. In other words, diagnosis helps bring order in this chaos. And in mental health, there can be a lot of things going on if everything is left vague. But here is the important caution. Diagnosis is useful, but it is not the whole person. It is a clinical tool, not a full identity. So when used well, diagnosis helps clarify. When used badly, it can flatten a person into a label, and that is where problems begin. So, clinical assessment is the broader process of gathering information about a person's symptoms, history, functioning, stressors, strengths, and context. Diagnosis, on the other hand, is the step where the clinician determines whether that presentation fits criteria for a specific disorder. So, assessment is wider, diagnosis is narrower. Assessment is the whole investigation, diagnosis is one conclusion within that investigation. Parang assessment is the whole case file, while diagnosis is one important heading inside it. This distinction matters because some students hear diagnosis and think that is already the whole clinical task. Not just yet. A good clinician does not just ask, what disorder is this? They also ask, what is happening in this person's life? What factors contributed to this and what keeps it going and what might help? So, reliability in diagnosis. Let's talk about it. Reliability means consistency. In diagnosis, it asks whether different clinicians looking at the same case are likely to arrive at a similar conclusion, or whether the same person would be assessed similarly across settings over time. So, why is this important? Because if diagnosis is wildly inconsistent, mahirap siyang pagkatiwalaan. If one clinician says major depression, another says adjustment disorder, and another says wala naman, then clearly we have a problem. So, reliability is about reducing that kind of chaos. It is one reason structured interviews and clearer criteria became important in psychopathology. The goal is not perfect agreement all the time because human beings are complex, but enough consistency that diagnosis becomes clinically useful and not just professional guesswork with confidence. Now, what is validity in diagnosis? Validity asks a different question. It is not just, is this diagnosis consistent? But is it actually accurate and meaningful. In other words, does the diagnosis capture what it claims to capture? A tool can be reliable but still not valid. For example, imagine a weighing scale that is consistently 5 kilos off. Consistent? Yes, correct. Pero ganun din sa diagnosis. You can be consistent and still be wrong. So validity matters because diagnosis should ideally correspond to real patterns, real symptom clusters, real course, real impairment, and ideally meaningful implications for treatment and understanding. If a diagnosis is reliable but does not really map onto lived reality, then it becomes less useful, even if it sounds official. So now, that's why we standardize, alright? When we standardize, it means that assessment procedures are carried out in a consistent way. Again, standardization means that assessment procedures are carried out in a consistent way. The same test is given in the same manner, scored using the same rules, and interpreted using the same standards or norms. Why do we need that? Because if every clinician gives a test differently or interprets it based on trip lang nila, then the results become difficult to compare and trust. Standardization helps make assessment more stable and more defensible. It is one of those things that sounds boring on paper but is actually very important in practice because without standardization, assessment becomes messy very quickly, and mental health work is already complex enough without us adding chaos as a hobby kung hindi ka marunong mag-standardize, right? So, what are the core methods of clinical assessment? Clinicians use different methods of assessment because, again, no single method can fully capture a person's psychological functioning. Common methods include the clinical interview, behavioral observation, psychological testing. We also have self-report measures, neuropsychological assessment, and in some cases, medical or psychophysiological evaluation. This is important because people do not always present clearly. Some clients are very articulate but hide a lot. Others struggle to explain what they are feeling. Some underreport, some overreport. Some are accurate but incomplete. So the more angles we use, the better the picture becomes. In short, good assessment is not one source only. It is usually a combination. Parang hindi ka magde-decide tungkol sa buong series based on one screenshot lang. So, of course, you need a fuller picture. So, the clinical interview is one of the most important tools in assessment because it allows the clinician to gather information directly from the person. Okay, the information you can gather or the clinician can gather includes symptoms, history, stressors, the kind of relationships, the way of functioning, coping mechanisms, and current concerns. But the interview is not just about asking questions, it is also about observing how the person speaks, thinks, responds, and relates. Minsan, the content matters, but so does the process. For example, does the person answer coherently? Are they guarded? Okay, slowed down, highly agitated, unusually expansive, or detached, or emotionally flat? So the interview gives both information and impression. It is not perfect. Of course, people may forget, hide, minimize, exaggerate, or simply not know how to describe what they are going through, but it remains one of the most central tools in clinical assessment, most especially if paired with clinical judgment. So now let's talk about structured interviews and diagnostic accuracy. Structured interviews are designed to improve diagnostic accuracy by asking standardized questions linked to specific criteria. In other words, instead of just going with whatever flows naturally, the clinician follows a more systematic format. This is helpful because unstructured interviews can be rich, but they can also be biased. A clinician might focus too much on one detail, miss something important, or interpret answers differently depending on style, expectations, or even fatigue. At the end of a long day, even professionals can become vulnerable to close enough thinking. So, structured interviews help reduce that problem. They support consistency, improve reliability, and can lessen the chances of overdiagnosis or underdiagnosis. Hindi sila magic, but they do give the process more discipline. Now, DSM is used as a classification system, all right? The DSM, or the Diagnostic and Statistical Manual of Mental Disorders, is one of the most widely used classification systems in mental health. It provides criteria for identifying disorders so that clinicians, okay, researchers, and institutions have a common framework. And that common framework matters because without it, each clinician might use completely different language and communication would become much harder. Imagine one person saying severe nervous instability, another saying emotional collapse, and perhaps another saying panic syndrome, and all of them meaning different things. So, alam natin medyo magulo. So the DSM helps standardize the language of diagnosis, but it is important to remember that it is a guide, not a substitute for judgment. The DSM can organize information, but it cannot replace careful thinking, context, and formulation. There are strengths and criticisms of the DSM. Okay, one of the strengths, okay, of course, it improves reliability by offering a clearer criteria. It gives professionals a common language. It supports research, communication, and treatment planning. But it also has criticisms. One major issue is comorbidity. The fact that many people meet criteria for multiple disorders at the same time. Another issue is that some categories do not map neatly onto actual causes or mechanisms. In other words, just because two people have the same diagnosis does not mean they got there the same way. There is also the risk of over-labeling, over-medicalizing, or treating categories as more solid than they really are. So, again, the DSM is useful, but it is not sacred text. Helpful, yes, all right? But again, this is used as a guide, okay? A useful guide. So, there are two kinds of thinking in diagnosis, okay? We have categorical and dimensional thinking. Categorical thinking means a person either meets criteria for a disorder or does not. It is a yes or no approach. So we discussed the DSM, it has criteria. Does the person meet the criteria? So that's categorical thinking. Dimensional thinking, on the other hand, sees symptoms along a continuum, mild to severe, occasional to persistent, lower impairment to higher impairment. Both ways of thinking are useful. Categories help with decisions, communication, and formal diagnosis, while dimensions help capture reality more accurately because many symptoms do not appear in all or nothing form. For example, anxiety is not something that suddenly appears only when it qualifies as a disorder. It exists on a spectrum. Same with depressive symptoms, obsessive traits, or attentional problems. So, dimensional thinking helps us avoid the trap of acting like people are either perfectly fine or officially broken. Real life is usually more nuanced than that. And now, one reason diagnosis gets complicated is that many symptoms are cross-cutting, meaning they appear across different disorders. Sleep disturbance, irritability, poor concentration, anxiety, hopelessness, and avoidance can show up in multiple conditions. Then there is comorbidity, which means a person meets criteria for more than one disorder at the same time. This is actually very common. A client may have depression and anxiety, trauma and substance abuse, OCD and depression, or personality difficulties plus mood symptoms. So the clinical reality is often not neat. Hindi siya one disorder, one clean presentation, one dramatic reveal. More often, it is overlapping symptoms, layered problems, and interacting issues. That is why diagnosis requires careful judgment or clinical judgment. You are not just matching symptoms to a list, you are trying to understand a pattern. Now let's talk about culture and diagnostic assessment. Culture matters in diagnosis because it affects how distress is experienced, expressed, explained, and responded to. The same symptom can mean different things depending on cultural context, language, values, and belief systems. For example, some people express distress more physically through headaches, body pain, fatigue, or stomach symptoms. Others express it more emotionally or verbally. Some communities normalize emotional restraint, and others encourage emotional expression. Some experiences that look unusual in one context may be understandable in another. For example, West versus East, right? So if clinicians ignore culture, they risk misunderstanding the person. And once the understanding is off, the diagnosis can also become distorted. In short, culture is not an optional side note. Kasama talaga siya sa assessment. Now, the cultural formulation interview, or CFI, is a DSM-based tool designed to help clinicians assess the cultural context of a person's difficulties more intentionally. It asks about the person's cultural identity, how they understand the problem, what stressors or supports are present, and how culture affects the clinical relationship. This is valuable because it pushes the clinician to ask, not assume. And in mental health, assumptions can be dangerous. Minsan akala ng clinician resistance pero culturally shaped caution pala. Minsan akala psychopathology pero culturally meaningful practice pala. So the CFA is one way of bringing humility and structure into culturally informed assessment. Hindi siya extra decoration. It helps the clinician see the person more accurately. And of course, there exists the bias, okay, in terms of race. And let's talk also about diagnostic humility. Assessment is not done by robots. It is done by human beings. And human beings have biases, right? Whether we admit it or not. So this includes cultural bias, racial bias, gender bias, class bias, and also assumptions about what normal should look like. That means clinicians can overdiagnose, underdiagnose, or misinterpret symptoms depending on how they see the person in front of them. This is why diagnostic humility is so important. It means recognizing that your first impression may be incomplete, biased, or just wrong. Humility does not mean uncertainty forever. It means being careful, reflective, and willing to revise your understanding, because honestly, that is a good rule in life also. Lalo na when people are too confident after hearing one symptom and one childhood story. So now let's go to case formulation beyond diagnosis, and this is where we bring everything together. Diagnosis identifies the disorder pattern, but case formulation explains the person. A diagnosis might tell us that a client meets criteria for major depressive disorder, but formulation asks, why this depression? Why now? What vulnerabilities were already there? What triggered it? What keeps it going? What strengths or supports exist? And what kind of intervention makes sense for this particular person? So, formulation moves us beyond labels. It integrates history, context, stressors, coping, beliefs, relationships, risks, and protective factors. And this is where the work becomes more human and more clinically useful. In short, diagnosis names the problem. Formulation tells the story of the problem. And if you stop at diagnosis alone, parang title lang ang nabasa mo, hindi mo binasa ang buong chapter. So that completes part 3, and here are the references I used for parts 1, 2, and 3. Up next, we will talk about the major disorder families. So stay tuned. Thank you so much for listening.